Welcome to Your Health Matters. I'm Jamie Taylor. I'll be your host today. This program is brought to you by Kingman Regional Medical Center, your community-owned hospital. This program focuses on healthcare issues, providers, and services that are going to provide information that is going to be useful for you and your family. I hope you'll stay tuned because I have a great guest on the program today. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is a brand new radiation oncologist at KRMC, not new oncologist, but new to Kingman Regional, Dr. Michael von Tuyl. Thanks for being on the show today,
It's my pleasure.
So when I said that, you're brand new to Kingman. When did you move here? It's been
Just 2 months ago.
2 months ago, so
Yep.
it's brand new, getting adjusted, settling in. But you're not obviously a new radiation oncologist. So where did you come from and what were you doing before Kingman?
Well, just prior to Kingman, I was just outside the St. Louis area. I've been there for a couple years. I went there to open a brand new cancer center. I was the medical director there. When this opportunity opened up here, it gave me a chance to kind of come back home or back to the area where I was kind of raised. I actually grew up in Las Vegas. So
I didn't know that. Okay,
Yep.
very good.
Yeah,
So you're close to home.
yeah, it's kind of nice to be back near family again.
Yes.
So
you still have family in Vegas then?
Oh yeah, my grandmother, my folks, my sisters are all still up in the
Okay.
Vegas Valley. So
I bet they're glad to have you closer
Very
too.
glad.
Very
Very
good.
glad.
Yeah, and it's a quick jump up to Vegas from here.
Oh, that new road is amazing.
It is. Oh yeah, when compared to driving across the dam,
Mhm.
it makes it a short trip. So that's awesome. So you have your wife and children with you too?
Just my wife. Both of us, our kids are all grown up,
very
away
good.
and married, and
Oh,
so
wonderful. Yeah.
it's just us and the dogs now. So that's kind of
Okay.
nice.
That is good. That is good. So what brought you to Kingman? I know you were wanting to be closer to family, but what helped you choose Kingman Regional? Because obviously you had some other choices.
Yeah, this opportunity here was fairly unique in that the radiation oncology aspect here at the cancer center had been kind of handled by a contract in the past.
Right.
And the administration here decided they wanted to kind of go into a new direction and grow the practice, and so they were looking for someone who had experience doing that, as well as experience in oncology to be able to make the transition here and grow the practice in the way that they really wanted to see the cancer center grow it. So this was a very nice opportunity for me, and this is the type of thing I've done in the past. So it was a very nice fit for both of us, I think.
Good. Well, we're blessed to have you here because I think, and that you've made the commitment to be in Kingman is good too, versus I think in the past the contractual doctors we had were usually out of Phoenix or
Right.
that area, and they'd be back and forth, and it makes a difference, I think.
It does. It really does. I mean, you've got to have some ownership into what
Absolutely.
you're doing, and a commitment to the facility and to the community. And when you're a contract doc, you really
You
don't have that.
Right. I agree.
So, and I've done rural health in the
I was
past.
just going to ask you that if
Yep.
you've had experience in small rural communities. They are unique.
Yes, I have. I've practiced radiation oncology in North Dakota, and where I was in St. Louis was a small rural community
Okay.
as well.
Okay.
And I've also practiced medicine in very, very rural communities when I was in the military. So that's that's a non-issue for me.
Okay, very good. Well, it can be a challenge if people have only been in big communities.
Correct.
They don't quite realize how you're going to run into your patients, other people at Safeway and Walmart. And I find myself now when I do go to like San Diego or Vegas and we'll go into a restaurant and I stop and look around and go, oh, I don't know anybody here. Because in Kingman, no matter where you go, if you look around, you're going to run into someone you know.
Right.
Which I think is it's one of the things I love about Kingman. And the fact that we are close enough to Vegas or the ocean. You know, we're 5 hours to the ocean and an hour and a half to Vegas, 3 hours to Phoenix. So you can get your fix if you need those kind of the culture or whatever, something different, but still come back to that hometown feel of Kingman, which I absolutely love. You know, and I think it also, for Kingman Regional, has played a major impact on our patient satisfaction scores, because one of the reasons they're so good is the fact that we're caring for our neighbors and our friends and our family. You know, it's not someone you're going to see in the hospital and never see them again once they're discharged type of thing. So.
Well, and not only that, but when you talk about cancer care as well, I mean, that's really huge, and there's a lot of worries that go on with that.
Right.
And when you add on top of that, you know, the loss of your support system if you've got to travel outside the area, the additional expense, I mean, the economic times are just what they are right now, and they're not good, and it affects everybody across the board.
Right.
So to be able to offer a comprehensive cancer program right at home, where you don't have to travel, where there's no expense in gas or wear and tear on your vehicle, or added stress on your family because they've got to take time off from work to drive you or things like that, is huge. Huge for patients.
Yeah, I totally agree. I when we opened the cancer center, that was one of my first events as a PR director for the hospital, and I said, what a gift for our community, just because of that, to be able to know you're able to do your chemo and your radiation right here. And I've often said, if you're sick and the treatment you have to have could make you sicker, then you don't want to be in a hotel room surrounded by strangers. You want to come home to your own bed with your family and friends around you. And like you said, I would think the more important than anything as a cancer patient fighting, to keep that stress as low as possible. So again, importance of staying home. So radiation oncology, there's two sides, my understanding, to treating cancer. It's the chemo and radiation. Okay, so what does the radiation do?
The radiation, we actually use a machine called a linear accelerator, which is a big fancy x-ray machine, basically, that generates radiation, and we use that to treat tumors. There's a whole, I like to tell my patients, part of what I do is not rocket science, but part of it actually is. The treatment itself is really pretty straightforward in that we come up with a set of beams that aim at the tumor and wrap our dose around the tumor and treat it and kill the cancer cells. That's the whole goal of treatment. Getting to that is very complex, but that's basically what it is. And because we use x-rays, it's like any other x-ray most patients have ever had. You don't see anything, you don't feel anything, nothing touches you, nothing hurts.
That's kind of cool.
Yeah, it is very cool. That part is very nice. But radiation is given every day, Monday through Friday, weekends and holidays are off, and we're usually looking at somewhere between, normally 6 to 9 weeks of treatment. Which is the downside of radiation, because you got to come in every day, and it's for those many weeks and stuff, so it can get a little bit tiring.
Sure. And now, when that radiation is going to the tumor, the ultimate goal is what? To shrink it? What happens?
Well, to kill it. That's what we're after. We want to kill the tumor. We want to eradicate it. We want to cure the cancer. We just don't want to, knock it down and,
So I wasn't sure,
back.
Truthfully, if we're shrinking it so then it can be removed, or I guess every case is different.
Every case is different, and it depends on the area of the body that we're treating. Sometimes, very often when you treat cancer, you're using a combination of surgery, chemotherapy, and radiation therapy to affect our cures. And we're curing a lot more cancers now than we ever did, even 10 years ago.
That's pretty amazing.
So, but it's based on our surgery techniques have improved, our chemotherapy. We have far more chemotherapy agents available today than we ever had in the past. Back in the 60s, we had like maybe 4 drugs. Now we probably have 400 or more.
Wow.
And radiation therapy, again, has the technical advances that have occurred in radiation oncology have been astronomical. I started my training 19 years ago.
Okay.
And I can truthfully say that the way I was trained is not how I practice my specialty today, because the technology has advanced so much that you just can't do the same things anymore. We have the technical advantages now that instead of just kind of treating large areas of tissue like we did in the past, we can really focus in around a tumor now, no matter how small it is, and really concentrate the radiation in that one area to give a good high dose there that kills the tumor cells. But at the same time, the techniques have improved so that we're minimizing dose everywhere else in all the other tissues, which cuts down on side effects and complications.
Sure, because that was one of the things I was going to ask you about. I've heard in the past, I mean, I myself fortunately have not had to experience it personally, but that in the past you'd have burns on surrounding tissue areas and things like that.
Yeah, I mean, you know, everyone comes in and says, well, Grandma had radiation and she got burned to a crisp.
Yeah.
And in those days, that was true.
Okay.
But the techniques and the radiation was completely different. What we're doing now, it's rare for me to see a whole lot of skin reactions.
Okay, that's good.
You know, there are certain areas that we treat that we do see that because of what we have to do because of the tumor location. But other than that, our side effects have really, over the last 15 years, have really taken a nosedive.
That's awesome.
And patients tolerate them so much better now.
That's great. So obviously whenever someone gets the diagnosis, that's scary, the big C as they say, and it sounds from what you're saying that it shouldn't be as scary as it used to be.
Correct.
I mean, obviously it's still a life-altering diagnosis. There's lots of changes.
Yeah, but it's not the death sentence that it used to be, you know, 20 years ago.
Right.
It just isn't anymore. We're so much better at detecting cancers when they're earlier. I mean, all you have to do is take a look at what we've done with men with PSAs and the diagnosis of prostate cancer. You take a look at what we've done with mammography, with breast cancer, and we are curing these cancers now because we're diagnosing them much earlier. And as the technology continues to improve and we get better lab tests and better x-ray tests and things along those lines, we'll continue to start detecting tumors much earlier, and with that our cure rates are
sure, because that's the whole thing, is catching it early, obviously. So I think we'll touch base again after we're going to take a break for a few messages, but then I'd like to talk more about how a person first thinks that they might have cancer. We're talking about catch it early, the things they should be watching for maybe. So we'll get back after these messages and talk more.
Excellent. Thank you.
Stay tuned. We'll be back right after these messages. Welcome back to Your Health Matters. My guest today is Dr. Michael Von Tuyl. Thanks for being on the show, Dr. Von Tuyl.
My pleasure.
So, Doc is the new radiation oncologist here at KRMC. We've been talking about the changes in the last few years that have brought about so much better treatment of cancer, and the fact that it's not as scary as it, or shouldn't be as scary for people. I'm sure everybody still, when you get that initial diagnosis.
Absolutely.
You know. So what do you see in the future for cancer? I mean, you think it's totally curable? Will we eliminate cancer altogether?
I think that's a possibility. I mean, we're getting closer and closer to understanding, you know, cancer, what causes it and what triggers it and what genes are involved. But it kind of falls into the same thing, like, are we going to get a cure for the common cold?
Right.
The problem is, like with the cold, there are so many different viruses that cause it. You can come up with something for one virus, but the next virus is something different, and you still end up with the same symptoms. When you look at cancer, and that word encompasses literally hundreds of different types of cancer.
Okay.
It's not just one thing.
Right. And it depends on the body part that it's affected.
Exactly. So as we're getting smarter and smarter medically with what's causing the different types of cancers, then we can focus in on those aspects of it, eliminate them, and at that point, can we eliminate cancer? Possibly so.
Yeah, okay.
It's like an example is breast cancer.
Right.
5 years ago, actually 10 years ago, we were actually getting into what we call gene arrangements of breast cancer. Before, when we looked at a tumor under the microscope, we could say whether it was well differentiated or well behaving, or moderately or poorly differentiated, or aggressive
Really
behaving.
aggressive.
But that was all we could do, was look at it under a microscope. We really couldn't tell a whole lot else about the tumor, especially its characteristics or its behavior.
Okay.
Because when we take tissue out, all we can do is say, what is that tissue at this point in time?
Right.
But now that we have the tissue, we've come up with what we call gene arrangement studies that will actually look at the different genes that are involved with that breast cancer and give us a much better view based on the types of genes. And if you're talking some of the tests, you'll look at 17, 25 different genes.
Wow.
And it's like yes or no on them, kind of
Okay.
like a computer. Well, if you've got 25 that are all no, well, guess what? That's going to behave really well.
Yeah.
We're going to do really well with that. If you got 25 that are all yes,
It's more of a
that's
challenge.
even though it may be one of those well differentiated ones we called before, we know its behavior is going to be more aggressive. So with that, now we say, we see this, we're going to do more. We're going to do chemotherapy. We're going to do other things now. And because we can recognize aggressiveness in some of these gene arrangements now, we're doing better.
Okay.
So again, as that specialty and as those tests improve, our outcomes are going to improve. Again, because now we're also looking at the genetics of the tumor, and we're looking at gene therapy, specifically tailored treatments, looking at those genes and targeting them,
Okay.
which again is good, because then you're targeting only those cells that have those genes, not all the other cells in the body. So
Okay.
we're becoming much more specific in what we're trying to do with cancer and how we're trying to battle it. So
Okay.
at some point in time, we're going to start
Yeah,
eliminating some of them.
That sounds
Yep.
like there's a nice bright light on the horizon.
It's getting better.
Yeah.
It certainly is getting better.
So it's obviously a team approach to,
Very much
to
so.
fighting cancer. I mean, it starts what we talked about with the radiologist and the diagnosis at the beginning, to make sure we catch it early, as we said. And then, do they do radiation next, or chemo, or what's the kind of progression?
It depends on the tumor.
Okay.
Okay. There are many tumors that we may start with chemo and radiation first, or chemo first to try to shrink it down, then do a combination. There are some tumors that we do surgery first,
Okay.
and then follow that with chemo or radiation, depending on some of its features. So there really isn't a set cookbook, shall we say, as to who comes first and who does it. That's why cancer care is so complex, and why it needs what we call a multidisciplinary approach. And that's where you get all the doctors that are involved with diagnosing a cancer and treating a cancer. You get them all in one room so that they can go over the results of a specific patient and actually come up with a consensus as the proper way to treat each individual patient.
Okay.
Again, there are patient factors that contribute as to what we do and when we do it too. If somebody has, cardiac problems and can't have surgery, well, then we're going off in a different pathway. But if they can have surgery, then we may consider surgery first and then follow up with the other treatment modalities.
Okay.
So what we try to do at these multidisciplinary meetings, often called tumor boards, is get everyone together so that we can have a complete picture of the patient, what's impacting on their overall health care as well as their diagnosis, and what would be the best current plan to treat them in order to eradicate this new problem.
Wow, that's awesome. So, and I know, of course, I've had a few of the new Mayo-trained radiologists that we're blessed to have here at KRMC on it, and so that is great that you're working as that team approach, and the patient obviously is part of that team as well.
Absolutely.
To make sure that they're understanding what the process is, and I would think that they have some responsibilities on their part too, whether it's eating healthy, keeping their stress level and those kind of things, right?
Yeah, no, that's absolutely true. There's a lot of things we can do for patients, but there's certain things we just can't do for them.
Right, they have to do it themselves.
They have to do it themselves. It's like my patients, there's often times when they'll lose their appetite, they don't want to eat, whether it's because of the disease process, or if I'm treating the head and neck area, we take out their taste buds go away, so everything tastes like cardboard.
Now, is that permanent, or is that
No, that's temporary.
Comes back?
That's
okay.
temporary.
That's a
But
good
it
thing
is
to know.
it is one of those things. If you can't taste anything, what's the point in eating?
Right. Well, you've got to
But
feed your body to keep
that's
it
just,
strong.
But that's just exactly it. And the one thing I can't do for them is eat or drink for you, as much as I might like to. But that's something on them. But we have nutrition services that we have go through their diet with them and help them with that whole process. But there are other things that we will address, such as smoking and drinking, which do contribute to not only the cancers themselves, but also can interfere with the healing recovery process, can interfere with some of the chemotherapy and other things that we do with treatment, and can also again increase their risk of developing a second cancer.
Again, right? Yeah. I think once you battled it once, you'd like just as soon not do that again. You'd think.
You would hope.
Yeah.
You would hope, but it's not uncommon for us to see patients who have had multiple cancers, and we cure one and they get another one. You cure that one, they get another one. So, and many of those are just lifestyle.
Right. Okay. So it's not just genetics. I mean, obviously genetics can play a part in that if you have a family history of breast cancer, things like that.
Correct.
But there are also things that you can do as an individual from the beginning to make sure you don't, or to do your best to fight it.
Exactly.
Now, I know that we've talked with some of the radiologists, and they've been amazed at the high levels of cancer that we have here in Kingman, especially lung cancer. They said that they diagnose a new one almost every day. And I would think for yourself as well, you're talking about this treatment plan that can take 6 to 9 weeks. So you obviously build a relationship with these people. You're seeing them on a daily basis. That's pretty amazing.
Yeah, we see they're in every day for treatment. I evaluate the patients once a week while they're under treatment to make sure that everything's going okay, answer any questions, address any concerns, and to make sure they're tolerating treatments fine. Keep a close eye on them. And then even when they're done, there's close follow-up after that. There are national guidelines that say you should be seeing your cancer patients every so many months for the first couple years, and then years 3 through 5, every 6 months or so, and then after year 5, once a year. So there's, even after they're done with their treatment, there's a lot of things that go on from an oncology standpoint that we stay actively involved with the patient in what we call surveillance to make sure that what we did was successful and that we're not seeing any signs of tumor recurrence or development of any other disease.
Okay. So I've always been curious when you have cancer, but you don't know yet you have cancer. I mean, what are the early warning signs, or what are things besides? I mean, obviously women do your daily check and you have your yearly mammogram, but what other things should you be watching for?
That is such a tough question to answer, because each tumor again can have completely different presentations. There are certain tumors that can be completely silent, and you'd never know they were there
Huh.
until it was already spread to other places.
Wow.
One is prostate cancer.
Mhm.
The only reason why we started to find prostate cancer was because of the blood test, the PSA, which
Okay.
started about 20 years ago.
Yeah.
Up until that point, unless the prostate got to a point where it was causing some symptoms, which it very often didn't do,
Right. You wouldn't even
most
know.
most men were diagnosed when they developed bone metastasis.
Mhm.
So
Well, I think that's going to be a whole topic for another show.
Yes, it would.
Okay. Well, thank you again for being on the program. It's great to get to know you better. And I thank you for joining us. I'll have another great guest on the program next week. I'll see you then.